I'm Sharon Brett Kelly, and today on The Detail, how the dying are cared for in New Zealand. In 2015, we ranked third in the world in the Quality of Death Index. Now we're at 12th. Today I'm going to find out why and about the role of hospice, which provides that care for free. And I want to know why it's getting more difficult to fund that kind of care. So my first stop is at a hospice here on the North Shore, and I'm going for a bit of a tour to see how it all works. Just a few facts and figures on my way in. 32 hospices across the country cared for 10,800 dying people last year, about a third of everyone who died. It cost $186 million to run hospice last year. The government pitched in about half of that, $94 million. The rest was topped up by donations, funding events, and takings from hospice op shops. And unbelievable as it sounds, these shops are crucial to hospice's survival. But as Hospice Chief Executive Wayne Naylor says, we don't talk about dying. There's no strategy in place around how we care for people who are dying, and no planned investment in the sector.
Dying is not something that we like to acknowledge happens in our medical system. It's not funded, it's not really recognised.
But walking into this newly revamped hospice, it is hard to believe it's facing a funding crunch.
If we go into this next room, so here, should people need physio intervention, then we've just got some equipment in here, nice bright room. It can be used as a massage therapy room. So it's pretty multifunctional.
Is this for people who are staying here or outpatients, either?
Either. So patients that are staying in the inpatient unit, our therapists or our clinicians will go down and see them there. Or they can come up here.
How many outpatients do you see here a year?
A year, that's a really good question. Not as many as we'd like to, since COVID was trying to build that up. So our future would be to see more people here. Some people that come on to our service early don't particularly want us to be visiting at home. They would prefer to come in and see us. It also gives us an opportunity to show what our building looks like, because as we know, it's quite scary for some people to be invited into a hospice environment.
What I've learnt about hospice, what I knew about hospice was the amazing op shops everywhere, but I've learnt a lot more in the last few days. And the thing is that hospice has a bit of a stigma as a bit of a scary place that you come to in your last days. It's much more than that.
It certainly is. Hospice philosophy is about helping people live as well in any way that is meaningful to them. If we see people earlier in their illness, it gives us time to plan a care with them on what is important to them and what is meaningful. So we're not just a place where people come to die. We're a place where people can have their symptoms managed. We can look after their psychosocially, their spiritual care, and their cultural care.
It's a very nice facility,
it's
what
beautiful.
I've seen of it so far.
Yes.
So how did you fund this? Because money seems to be the big issue for hospice.
It certainly is. So it was a 20 million capital campaign. 10 million was contributed by our Development Foundation and 10 million by our wonderful, generous community.
You're constantly reaching out to people to give money?
Absolutely. 50% of our funding comes from our community to enable us to provide what we can provide for the people that need us.
If it's getting more and more challenging, is what I'm hearing, to raise that money from donations, this funding model doesn't work, does it?
Well, it's going to be a real challenge for the future, but it's like everybody. Yes, the population's getting older and living longer, So we're going to see a different illness trajectory. We know we're going to see an increase in dementia and frailty. We're also seeing an increase in complexity because treatments are better than they used to be. So when people come onto our service, the needs are more complex. So that's going to be the future for hospice, really.
As if caring for the dying is not difficult enough, imagine what it must be like when other health services are crumbling around you. Community funding has hit the limit, but the elderly population is growing, and reaching the dying in their homes can be treacherous. Just listen to this.
We had a nurse last week on night shift because we do 24/7 service and free of charge. She went out at 11 o'clock at night to Tahapu in the far north, and she got home at 4 o'clock in the morning. So, yeah, the rurality is a big issue, and also the security, because having nurses on the road through the night like that is a security risk as well.
Belinda Watkins is Chief Executive for Mid-Northland and Far North Hospice, looking after a population of 74,000 from Cape Reinga to just north of Whangarei. There is no inpatient unit in the region, which means that all the care is in people's homes.
So you can imagine that's not always feasible for people, especially in the far north, because it's a long way and there's a cost involved. So, yeah, but there's 4 to 6 beds available for the whole of Northland in Whangarei.
And how many people do you employ to run this?
So we've got 35 staff and we've got 400 volunteers go out and act as volunteer companions, right through to working in the shop, doing the gardening, baking cakes, things like that.
And how much does it cost to run?
So for Hospice Mid-Northland, it's about 2.6 million. And for the Far North Hospice, it's 850,000. So all in all, about 3.4 million.
Where does that money come from?
About 45% of it comes from government or from Te Whatu Ora. The rest we have to raise from the community.
That's a lot of money to raise from a community with a small, spread out population and a community that's largely quite poor. And we're in a cost of living crisis.
It is a lot of money. And for the Mid-North this year, we've got to raise somewhere in the region of 1.6 million. And for the Far North, for 450,000.
So that's $2 million it needs to raise from the community. And here's the surprise. More than half of that comes from its op shops.
We've got 6 shops. We raise about 1.2 million from our shops, and then the rest comes from bequests, donations, from fundraising, but it's really tight. It is really tight, and we've reached a bit of a ceiling, I think, on what we can expect to get from the community. So there's a lot of juggling by me to be able to meet the cost of the service and also keep that safe practice and excellence of service going for our palliative care patients.
You've reached a ceiling. What do you mean by that?
You can only ask the community for so much money. Yeah, you reach a ceiling of what you can ask for because, like you say, there's a cost of living crisis. And to have our hands out all the time asking for money gets a little bit tiresome, I think.
So what does that mean, Belinda? I mean, how does that affect the way you operate?
It affects the way, well, not yet, it hasn't yet, but we can't hire another nurse if we need to, for example. And we definitely have a much higher complexity of patients at the moment. So the need for more clinical staff is upon us. So to do that, we're going to maybe in the next year have to dig into our reserves, which as yet we haven't done. And our reserves are from bequests mainly and from good investment of the funds that we have. And that's all community And our clinical team are already saying to me that they're under-providing, which is something that's not great. They want to go away from that person's home thinking they've done the best job they possibly can. So
you're talking about a higher complexity of patients and staff feeling that they're under-providing. Could you give me an example of what that means?
And this isn't just because of our service, it's because of all the other services crumbling around us. So the lack of GPs, the lack of respite care, the lack of specialist palliative care, hospital staff who can assist us with transitioning our patients into the community. It's just a case of they can't provide the cares that other providers aren't providing. The other big inequity as well is home support up in the Mid and Far North. So we've actually hired a healthcare assistant to provide those cares for our patients because of the lack of service elsewhere.
I don't know if there is a typical case, but if someone from hospice was going in to a home where someone is dying, what kind of care would they be providing?
It's mainly symptom management, so it's pain relief and making the patient feel comfortable, so living well until they die. So it's not just the patient and that whole holistic approach to that person who's dying and their whānau.
How many times would they be coming to give that kind of treatment?
That varies quite a bit according to complexity, but towards the end of somebody's life, it would be at least once a day and sometimes twice a day when patients actually go on syringe drivers just to manage their pain until the last moment.
How do you think you will keep going and offering care that satisfies your staff as well as the people who are the patients and their whānau? What is it going to take, do you think? Because it feels like this current formula isn't working that well. So
we can do fundraisers and we can get another shop in the Far North. We've got options, but the expectation of us providing a 24/7 service free of charge is becoming quite difficult. Actually, we've come up with some innovations as well moving forward about providing care in people's homes for people who want to die at home who really don't have access to that IPU, and it's called Karawaihi and Manakitanga, and it's accessible, whānau-centred, need-based specialist community palliative care. So it's better supported deaths at home for our patients, and it's actually cheaper than them going into hospital by about $1,000 per patient. So back to that question, why has New Zealand slipped from 3rd on the quality of death indexes 9 years ago to 12th? Well, here's Hospice Chief Executive Wayne Naylor again.
It's not great because New Zealand has always done well when it comes to the care of people who are dying. I think some of the reasons that we've dropped in the ranking is, well, one, we don't have a current national strategy. The government hasn't renewed our 2001 strategy, so we don't have national direction. We don't have stable, sustainable funding for community-based palliative care, particularly provided from hospices. It's widely variable. And again, because there's no strategy around how we care for people who are dying, there's no planned investment in it. So services are struggling, not providing as much as they would like to. Our workforce training used to be fantastic. It's dropped away a bit. We're not training enough specialist doctors. We don't have funded postgraduate training for nurses anymore. And it's just not as well organised as it could be compared to some other countries.
This is a story that we're hearing over and over again at the moment, isn't it? Especially in the health sector. I mean, I'm looking at your funding model, 92 million from the government, 94 million comes from the hospice shops, from donations and other forms of fundraising. Is it not working, that model?
I would say that it's not really working. And what really brought that home was 2020, when we had COVID lockdowns. The hospice retail shops had to close. Many fundraising events were cancelled. In fact, some of this flowed into 2021 as well. And hospices were exposed because of their reliance on community fundraising and the secondhand retail. That money just wasn't coming in. And of course, the government funding doesn't cover the costs of all of the clinical services that hospices provide. So I think it's really made the hospice sector realise that although the community funding is very important, it's been a part of hospice since its inception in New Zealand and internationally, but it's not something that you can rely on all the time. We'll just take something again like COVID and hospices would be struggling.
It kind of seems like a crazy model, doesn't it, Wayne? I mean, second-hand shops playing a crucial role in funding a crucial service for end-of-life care.
I think that part of the issue that we've got around funding end-of-life care or palliative care really well is that it's been sidelined in our health system for so long. In fact, that's why hospices started in the first place, the first hospice by Dame Cicely Saunders, because she was seeing people in hospital being put at the far end of a ward to die with little attention from healthcare staff, often in pain. And so she took people out of the hospital into the community so that they could actually have a holistic approach to their end of life, be supported to be in the places where they wanted to be, because dying is not something that we like to acknowledge happens in our medical system. It's not funded, it's not really recognised. You'll see in our national strategies, if it's mentioned, it's maybe mentioned once. We have our national catchphrase for the health service: live well, get well, stay well. We petition to have dying well in there as well, but it's not there, even though every single person in the country at some point is going to die. It's just not acknowledged as a part of the health system. So therefore, it's never really been funded as a part of the national health system.
So you actually petitioned to have that die well as part of the slogan, and it was rejected?
Yeah, and we also tried to, with the restructure of Health New Zealand to Whatu Ora, we tried and supported actually some staff within Whatu Ora to have a dying well team established, because they've set up this life course system where they have living well, aging well, mentally well, starting well. We tried to get a dying well team in there, but that also didn't happen, I understand, because of internal concerns about using the word dying within Health New Zealand. So again, that I think it possibly comes down to this whole societal fear of talking about dying. It's just something we don't do. So even in our health system, we can't talk about dying. We did a survey, which we reported on the beginning of last year, asking 1,300 New Zealanders around what they understood about hospice, but also what they understood about death and dying. And I think at least 2/3 of people felt uncomfortable, might have been more than 2/3, felt uncomfortable talking about death and dying with someone who had a terminal illness. So if we can't talk about it, it makes it very hard to be prepared for dying, and it makes it hard to do lots of things, be prepared, understand what people want, set a plan for when the person's dying so that everyone knows what they would like to have when they die. It makes things much more complicated.
This is not the first time you've said, we need to talk about this. We need to look at the funding model where there's a funding crisis. So what, are you just being ignored?
It does feel like that sometimes. And I know that our health system has a lot of other priorities, but something has to change, because otherwise we'll see more people dying in circumstances that are not ideal. They won't have their symptoms well controlled. They might end up in hospital, and most people don't want to die in hospital. Their family won't be well supported. Hospice has a holistic approach, so the physical symptoms are managed, family is supported, the person's spirituality is supported, and their emotional well-being is supported as well. And if you don't have that wraparound holistic care, then it can be not a great death.
What do you want, Wayne? What do you want for hospice?
Well, hospices have been taking the lead in this because the government hasn't been doing anything for many, many years. So we've been working on a new way to fund hospices that particularly looks at any new funding going to resource gaps in service availability. We want to have much better workforce planning from central government. So we need good training programs. We need palliative care and hospice to be seen as a really good career option for health professionals. We need recognition that it's a critical part of our health system and that the government should fund it as such. We can't have hospices raising, probably this year, I reckon they'll be raising at least $100 million, if not more, to cover the costs of providing an essential health service. And hospices, by doing what they do, keep people out of hospital, out of emergency departments. They can help people to stay in a rest home if that's where they are, because they provide services in to support the aged care facilities. So there's a cost benefit component to it as well, and freeing up hospital services. So the government needs to recognise that as a investment in helping people to have a good end of life care, but also an investment in the wider health system.
And if all this came about, can we get back up to third in the world or even higher?
I think we could. If we had good investment, we had a good national strategic approach to what's happening with palliative and end-of-life care. If we had our workforce up and running with the right number of skilled people in the right place. We do need to work on things like hospital-based palliative care services. There are a number around the country, but they're often also under-resourced and they're not in every hospital. And we need other providers like aged care and general practice. They need to be well supported and probably actually have some specific funding to provide palliative care, because it's more complicated than just a normal 15-minute GP visit, for example. You need more time, at least an hour, to do a proper full assessment with the person. And sometimes they need to have that visit done at home because they can't travel to a general practice very easily. So there's things that definitely can be done and would definitely pull us much further up in the international rankings around palliative and end-of-life care. One of the myths about hospice is that people think it's a place to go and die. That's not what hospices are. In fact, many patients under hospice never go to the inpatient unit. They have all their care provided at home by that multidisciplinary health professional team as well.
Hospice has a fundraising push coming up. Hospice Awareness Week starts on May the 13th. That's all for today. The Detail is supported by RNZ and NZ On Air. This episode was engineered by Jeremy Ansell and produced by Alexia Russell. Thanks to Bev Platt, Belinda Watkins and Wayne Naylor. I'm Sharon Brett Kelly. Mā te wā.